let me first, before we
The
go on
pleasure
into
is
our...
mine, I can assure you, Noury.
Thank you so much, Dr. Ruth. You are very modest. Before we go on into our subject, I want to ask you at first about the recent article in The Sun about a girl who had her nose done. Could you tell me more about this?
Well, it was actually during lockdown, so it was a completely illegal anyway. But this, not just this one girl, but her friends, they're both university students. They said afterwards that they realised that they should have known better. They could see all the red flags flying, but they were. They saw an advert for the celebration of Eid, the Muslim festival, and a beautician in Bradford had put up an advert of which she had many takers, people queuing around the block for nose fillers to have their noses improved for the celebration of Eid. It was a case of butchery, to be quite honest with you. I really don't think beauticians should be doing these sorts of treatments. They have no idea about the anatomy or the dangers involved. They don't go on to any of the anatomical courses, such as the size, for example, in London, because we wouldn't have beauticians on the course to start off with. Anyway, it was a lot of needlework, and her nose was incredibly painful. Apparently it bled all the way through. And she tried many doctors on the Saturday to help her, and nobody would. One doctor said to her, wait 6 months and see how it is. Well, if it had been a vascular occlusion, that was no good. She'd have gone blind and her nose would have dropped off by that stage. So, I mean, it's just ludicrous. So it was 11 o'clock at night, or maybe 11:30 at night on the Sunday night. She texted me through Instagram and just shouted help. And it was a miracle that I was still up. And I saw this come up on my Instagram, and immediately I just felt such empathy for her. And there was no way I could not go into it further. So I asked her, what do you mean you've had dermal filler? When was this done? Who was it done by? And the picture got worse and worse. So, in fact, I carried on talking to her and asking questions and getting her to send photos until about 2:30 in the morning. At that stage, I feel I'd reassured her to a certain degree that I was going to get help for her the next morning. And then the next morning, I was on to it again at 7 o'clock in the morning. I actually sent a text down to Sabrina and some photos in London, who was very helpful. She also thought it was a vascular occlusion. But unfortunately, I didn't have any keys to our practice. So I contacted another doctor in Manchester, a little bit closer. And of course, he just suggested we did a video to check for immediate capillary refill. Now, she'd managed to sleep. She'd had a completely sleepless night the night before. The pain was getting a little bit less. And actually, she did get capillary refill, although I have to say, it looked nasty. It looked like she'd got vesicles down on the end of it, but that was purely just dreadful trauma from needlework. And in the end, we didn't have to do anything, but she was completely reassured. She went to an establishment, a company called Save Face, to report this. They were running an article. And they suggested various things, including having your money back. So she rang them up and complained. They gave the money back and then made it even worse by coming back the next day. And a doctor that had apparently trained her, she called him her senior. He came back and said, actually, you should give the money back, because whoever that doctor you were talking to, meaning me, doesn't know what she's talking about, hasn't got a clue about what she's talking about, which is rather a joke, really. You know.
And actually, it's very strange, actually. You know, it takes a highly skilled practitioner to do dermal fillers in the glabella region or the nose. So what she did, it wasn't that much easy. It's like not anyone who should be allowed to do fillers in those areas, which are very highly risky areas. So I guess
I don't feel beauticians should be treating and going under the skin anyway. I really
Yeah,
don't think. I
actually,
think it's
this is another point of of this whole thing, that despite that this area is risky, she was treated by someone who is not allowed or skilled enough or have the enough science to do those things. And actually, it's catastrophic. We do have the same issue here in Egypt. A lot of people who are not fully skilled or allowed to do facial aesthetics are doing those things. They just think that the whole speciality and the whole work is just a sort of a couple of injections. You place it in certain points. They don't know the anatomy. They don't know the landmarks. And
I
it's
have an
very,
analogy, and it's you put a learner driver into a fast sports car with no seat belts and just tell them to go fast down the fast lane in a motorway. You're
Mhm.
just waiting for a collision. It's like playing Russian roulette with a gun. A number
Definitely,
of
definitely.
cases. She had a lot of cases on that weekend, and it was a ridiculously cheap price. So
Mhm.
the girl went to the Sun in the end. They ran an article last week, and they asked me for a comment. But you know, it's a warning. I hope through these articles in the newspapers that it will put young girls like that off, because one of these days there's going to be a disaster. And I
Yeah,
think the sad.
it's a good thing that you spread this knowledge that people should be fully aware of what to do and where to do it.
Yes, and I also think the very sad thing to come out of this was that she approached many doctors on the Saturday and the Sunday. She only got to me at 11:30 on Sunday night, and none of them wanted to help her. There was one that offered some advice in Liverpool, but I do think that that in itself is very, very sad. We should be a
Exactly.
group of people who are prepared to support each other.
Yeah,
And
exactly,
that's what
exactly.
being a good practitioner is all about.
Yeah, exactly. I guess at the end is lucky to have you. So, Dr. Ruth, we shall proceed with the topic of our webinar today. We are going to speak about lip fillers, European lips, normal lips, the new trend of the Russian lips and the fake lips. And, a lot of the millennials like to do those 50-50 upper and lower lip. But before we start on lip fillers, we shall talk a little bit about the normal lip landmarks. We have the oral commissure, the white roll border, the cupid bows, the fulcrum dimple. If you could tell us more about the normal lip landmarks and what certain landmarks that you should be working on enhancing it while doing your cosmetic procedure.
Well, I like lips to look natural. Now, you may not be born with particularly endowed lips in the same way that, you may not be endowed in your figure. We're not all born in a perfect form. And so we're not all born to perfect proportions. So I do believe in natural lips, but there can be a point at which your lips could be a little on the small side, and you would certainly suit something enhanced a little bit. The point is, there's quite a range of normal. It's when you go over that normal, or you actually go against normal balance of anatomy, where things seem to go wrong. The sad thing that I find now is because so many people have pushed the anatomical bounds further, the younger girls, the trendsetters, if you like, the influencers, the beauty influencers, you get to a stage where the younger girls feel that what isn't actually what we would call as normal anatomical form, they start to believe that it is. So it's the power of what they're seeing all the time on the media twists the mind onto what looks normal. So what I would feel is normal is that we should have a certain angle from the nose of perhaps about 110 on a female, slightly less on a male, to what we would call the white upper lip. Really, all of this is the lip. It's not just the vermilion part, which is where a female would put her lipstick, but the whole area is actually the lip. You've got what I call the white upper lip, the white lower lip, and then the vermilion border. We've also got the outer part, which is the dry, and the inside, which is the wet. So we have a point just where the lips touch, which is called the wet-dry border. So the outer part is keratinized. We've got two nice little filtral columns, which aren't present on everybody, but if they are quite rigid. When I say rigid, they're quite pronounced, straight, slightly flared ridges, and the bottom of them is this beautiful arrowhead. Now, not everybody has that lovely arrowhead, but it's a nice feature. And so you've almost got a flared shape with an arrowhead at the bottom, but it dips in. And I always say that it will hold a drop of water. So when I've done this on, I've enhanced this on somebody's lips, I'll always pop a drop of water into it off the tip of my finger, and it will stay there. And earlier, it will have been completely flat, and that drop of water would drop off. Now, it gives a beautiful projection at the center of the lip. And what we're trying to do is have a concavity from the nose, from the ala of the nose, towards that border of the lip. So this is where you get your projection from. And that's on the upper lip. You'll have a little bit of a roll at the border, almost like what we call a milk line. This means that when you drink a glass of milk and a child leaves a white line behind, that's where it gives the name the milk line, because it reflects the light upwards. Now, underneath, to show a nice little bit of projection under the lip, we should have a little bit of a shadow just under the roll of the lip here, so that that goes into a concavity, which is the
labiomental fold.
Yeah, absolutely. And then you've got the projection of the chin. The contours are at the corner, and they should really be tipped up a little bit. When they're bent down, when the lips with aging start to lose their hyaluronic acid, they start to lose their I say to patients, they lose the stuffing, and they start to flatten and roll, and the tissues start to sag, or you get overclosure, as you will know as a dentist, flattening of the teeth and overclosing, so that you get the chin coming up closer towards the nose. You tend to get those lips thinning and turning down. Women hate that because it looks like sad mouth. Even though they may be happy, the resting position is no longer horizontal. So in a sense, a little bit like the Mona Lisa, that slightly tipped up corner, she looks as if, is she smiling or is she not? And that's the whole enigma about that painting, that she's got these beautifully supported connoisseurs. So I like to think of the lower lip as having a box. The central part there is, and like demonstrated on yours, Noury, it's more plump in the center. And I call that the box of the lip. It's the sort of, if the lip was in 4 parts, the lower lip.
Actually, I do have a natural Russian lip.
You do, very much so. That's right. You demonstrated better than my own. But that half.
Dr. Ruth, I'm gonna tell you something hilarious. Actually, we too represent the title of our webinar. You are European lips, and I do have the Russian lips.
that is representing half of the lip, with the quarter tailing away at the end. So really, that is the anatomy. And I would say that European lips, I would say females particularly, generally we would try and go from a 1 to a 1.6 proportion. Men 1 to 1. But it's not always possible, because you've got to play with the material that you've got there, and you don't always have that freedom. If you try and overinflate or overstretch the tissues, you can't in one session alone get the lips to necessarily be the ideal shape that you would want. And of course, you must bear in mind the different shape that you would want to give maybe a younger woman to an older woman. Even
and by the way, yeah, exactly. And speaking about the ratios, I guess most of the millennial patients are the patients who actually targeting to have a 50-50. It's very rare to find an older woman who wants this appearance. Actually, younger patients tend to look for fake looking. Actually, we are going to go back to this point again. But after you spoke about the normal lip line marks, speaking about lip anatomy, we know for sure that whenever you do an injection, you should be stay superficial as much as possible. Concerning this is going to be a safe injection, and at the same time, you will be able to place your product in a very precise manner and draw the lips the way you want it. I guess we should also take care not to inject too deep. Tell me more about the labial artery, its location, because you know there is always a risk of vascular occlusion in the lips, especially that's a very highly vascular area.
Yes, I'm in favor of a cannula technique. I remember talking to you a few weeks ago, Noury, and you said that in Egypt or the Middle East, the type of lip augmentation that you have witnessed is that they place the product into the lips and then they rely on massage to put it where they want it. And you said to me, watching my videos, but you use a cannula and you place it exactly where you want it and you don't massage afterwards.
And I want to tell you something. Sorry for interrupting you. Actually, concerning what you said right now, because I looked forward of what you are doing, I find a research that is actually highly supportive of what you are doing. This research suggests that injection with needles make the product tend to disperse in the tissues. However, when you do the injection with cannula, the filler product only flows at the plane where you placed your cannula, so it actually means stick to this area. So you are doing something, and I have to look forward about your techniques, and I found researches that are actually supportive of what you are doing. So I guess whenever we're going to talk about cannula and needle, cannula remains number one tool to be used.
I think that it's, number one, I think it's safer. You're going in through one tiny hole at the corner. I may be just using a little needle just to do the philtral columns and that fine Cupid's bow. I could not do that with a cannula because it's such a short area and I want absolute precision. I want precision anyway, but from the Cupid's bow point of view, you need fine needle precision. But apart from that, I just have one entry point at each corner. I slip in above the muscle. I can go down the border, then into the body at various levels if I wish. And as long as you've got, the key point is to have a very, very controlled plunger delivery speed, which is opposite then to the withdrawal.
A smooth buttering technique.
Well, no, that's not the buttering. Well, the buttering technique is where I flow it across the rest of the face. But I wouldn't say that I butter in the lips. I'm placing more in a linear fashion, but at a level where I want it. So if I go nearer to the wet-dry border, almost slipping behind the lips, I will get more projection forwards. If I go nearer to the border, I will get shape, but I won't actually lift the lips forward. So you've got to really look at the profile, the chin, the nose, Steiner's line to see where you want the projection. So that's very important. If you over project, they will look ridiculous. You've got
like Frankfurt or Donald Duck lips.
Yes, well, yes, I was going to say, yes, sort of duck lips. That's what people tend to call them. So you've really got to make your plan before you start. I see people just
Dr.
on
Ruth,
videos.
sorry for interrupting. We have a question from Aesthetic Interventions. I guess it's one of your followers. She is asking, what gauge cannula do you use? Actually, it's a very good question. Do you tend to use a high...
I use a 25 gauge every time. I find anything smaller, like a 27 gauge, which is thinner, is too much like a needle.
Exactly, yeah.
Anything wider than that, I think is too wide for me to go down the border to produce a nice fine border. I'm not somebody that likes a huge wide milk line. I like fine reconstruction, really, and very precise placing of the material. And really, the amount that you want to inflate the lips or enhance the lips depends on the type of products that you're going to use. So you might be using something that's a little bit more viscous. There are various ones on the market. You've got to choose the right one for the job, but also a slower speed of withdrawal. So you want a smooth pressing of the plunger, but it's a little bit like somebody trying to rub their head and rub their tummy at the same time. It's quite difficult to do them. People
Doctor,
find
do you
this
do
quite
it in,
difficult.
yeah, do you do it in a retrograde fashion or an antrograde fashion?
I do it in a retrograde fashion, and I very rarely place any filler material beyond the tip of the Cupid's bow. So in that central portion just there, unless the teeth are such that, this is where, as a dentist, and you would be the same, Noury, and maybe doctors don't always look inside the mouth, but if they have got centrals that's the two central teeth that are placed back and the lateral teeth are placed forwards, then you may want to actually augment that central bit because it doesn't have the support from behind. On the other hand, if you've got somebody who's got prominent central incisors, the two ones in the center, or even one of them is more crossed over and projected, the last thing you want to do is over project the central part of the lips because they've already got that support from behind. There's another thing that I would say, which I really wanted to talk about today before we go on to Russian lips, and that is, well, it's also to do with Russian lips, the various types of Russian lips, one of which I think is a hoax. But in general, I think when people are talking about today's younger enhancements, not that I like them, but the ones that become unnatural and the over-enhanced Russian lips. In the Russian culture, if I'm right, I believe that it is not the done thing to smile in public. They tend to smile at home with their families. Now, when you augment the lips, it will have a tremendous impact on the amount of tooth show. Now, let me take this
It will decrease the amount of teeth show.
Yes, because if you look at it the other way, when I'm treating people with gummy smile and they show too much maxilla, they have a sort of a maxillary vertical excess. What I do there is not only use toxin to sometimes stabilize that lip, but if the lips are thinner, I put more material in the curtains, so to speak, so that they will close across the teeth more easily. Therefore, I'm increasing the volume of the lips to a normal anatomy, but that gives the patient that has what we call incompetent lips, which for anybody that's not a dentist means they have to contract their muscles in order to close the lips together over the teeth. Well, if you increase the bulk in the lips, you can bring about that closure much more naturally. Having said that, the reverse is true. That if a patient doesn't show a lot of lip when they smile, and then you go and all they're thinking about is that their friend has larger lips and they want larger lips because it's all the rage with the young ones now. And you don't consider this and you enhance and you enlarge those lips, that patient may have tremendous difficulty in actually smiling. Because when they smile, we had a footballer called Gaza, Paul Gascoigne, and he was known for his reverse smile line. In other words, the teeth, well, you'll know what that is, but people that may not be dentists won't. But instead of the incisal edges of the teeth following the lower lip,
the curve of the lower lip, yeah, exactly.
It curves the other way, so the teeth curve that way.
It's like a reverted incisor and occlusal plane.
Yes, and you really have to lift that upper lip to try and show the teeth. Now, if you've got a patient that's either got a reverse smile line or they don't have much. They've got worn down teeth, and you get this even with the young children, the young girls and boys these days. But we're talking really, it would be a girl that wanted this sort of look. You could create a tremendous difficulty on them showing the teeth in the first place. And you see, I regard the teeth, as you know, Noury, I regard the teeth as the picture. I regard the lips as the inner frame, the perioral area as the outer frame, and then the rest of the face as the frame that goes beyond that.
Yeah,
So
you know, Dr. Ruth, I guess when people tend to do the Russian lips, they are not actually thinking of the way they look when they do smiling. They
no,
are actually tend to focus on how they are gonna do the pose for the Snapchat or the Instagram pictures to look like
exactly.
models. But it actually, if when they tend to look at their face, whenever they are gonna do a facial expressions, they are gonna look horrible.
Exactly. You see, people think, and they have these 10-minute, 15-minute sessions in Liverpool to restore lips. In they come, they get the needle, and they just think about plumping the lip. And sometimes they make it almost amorphous, that it has no detail and no beauty. There are fine features on the lips which are to be preserved. And that's what they do. And the girls go out feeling bigger lips. That's just what they want. Maybe bigger breasts, bigger lips, you know, bigger everything. And, well, you know, it is, we're in an age of over-enhancements. And actually, they're going well away from what is natural beauty. And you can't beat natural beauty, as if this is what you've grown like, that you just got, you know, these good features from your parents. And that's what I would think good facial aesthetics is all about, is trying to enhance to the point where you look like you've come from a line of good racehorses. I mean, you know, I don't mean racehorses, but, you know, you've come from a very good lineage
Yeah.
of
Dr.
beauty.
Ruth, do you agree with me that we do highly encourage patients to go on for Botox and filler at a young age, but at the same time, doing excessive lip plumping with fillers at a young age may result in an internal scarring in the internal tissues of the lip, and
Absolutely.
and over time, this is gonna like make your lips look horrible.
Absolutely, Noury. And this is my worry with needling. When young girls are having, or anybody is having a needle procedure, they will create more trauma in the lip, which will in turn cause more collagen production. And what will happen anywhere, I mean, you see it on the soles of your feet, wherever you have a lot of trauma or you take the skin off more, you produce more. And you can see it on sometimes lesions on the face, even where you've had a bite and, you know, somebody scratches away at it, they will get sort of harder corns. The same thing will happen in the lips. Lips are supposed to be soft, bouncy, and dare I say it, very kissable. That's the, you know, the lips I regard as the only visible sexual organ. You know, it is an oral, it is an instrument for the voice. It is an expressive tool to show whether you're sad or you're happy. But it's also, people kiss with their lips, they pucker their lips. And if they become very rigid and firm with a lot of collagen production, which has come over the years from a lot of puncture wounds from needling, from the tenting design, the tenting or the pillar design, you will get harder, firmer lips. Somebody I know once said, like the end of a dog's nose. You know, and I've had patients in like that, this.
Yeah, but by the
And
way, we want to tell our audience that the lip tinting or lip filler pillar or Russian lips are like different names for the same technique of doing the Russian lip. Dr. Ruth, before we go, I want to start with the difference between European lips and Russian lips, but we have a question from Aesthetic Interventions. She is asking, how far from the oral commissure do you insert your pilot needle for cannula? And what is the most lateral entry point you recommend? Of course, you know that the labia, the facial artery is 2 centimeters from the corner of the mouth. So whenever you do your pilot drill, which area precisely you place your pilot needle? This is a question. And actually,
you reminded me of placing dental implants then. You said the pilot drill.
yeah, yeah, and I want to tell you about something else. Some people, you said that you do a single entry point here. Some people do like 2 points, one for
Oh,
the
yes.
upper lip and
No,
one
no,
for the
look,
lower lip.
that is fine. I sometimes do 2 points.
Hmm.
I go in twice. I go in two different directions, but I try and do it from 1 point now. But it's not always possible. You've got to look at the individual lips. I go in, I don't go literally at the corner, at the commissure, on the vermilion border. The reason that I don't do this, and anybody who's not had their lips done, so that would probably be a lot of men operators, they won't be aware of how it feels like after the event. If you go in just on at the very corner on the vermilion border, you get a horrible after effect of feeling like there's something like a little spot right at the corner of your mouth, and it seems to affect the closure. It's to affect the oral closure, and you feel like you're dribbling. So I go just outside of that onto the skin, but not very far away, because yes, I mean, I always think of the anatomy, the greatest concentration of vessels being about 1.5 centimeters away. But you can be right, I can be right, as Sabrina Shardasai would know if she's watching tonight. There's a tremendous variation on anatomy. Am I right, Sabrina, if you're there? So, but no, I don't go that far out. I literally just go maybe 1 millimeter, and I tend not to go in a horizontal direction. I tend to go just upwards. So I try to tip the corners up by making the circumference of the lower lip longer than it started off, and the circumference of the upper lip shorter. Because if you think of, oh, I can demonstrate with this. If you think of a smile like this going up, this distance is longer than this distance. If I turn it upside down into a sad mouth, this is now longer than this. And if you've got somebody with a sad mouth, we want to actually correct the balance and bring it back like this again. So I tend to make the entry point a little higher, and I almost
So as when you are injecting the filler, you are like drawing it in an upward manner, so we'll give this tapered of a happy look instead of a sad look.
Well, yes, but also by going in and I'm pretending that the new commissure is higher than it was before. So I'm almost pinching a couple of millimeters of the upper lip circumference to give to the lower lip. So I'm actually creating a longer circumference, and it works beautifully. And there's another couple of little tricks for lifting the corners of the mouth as well, which sometimes I may need to use as well.
Okay, doctor, do you prefer to inject like a bolus of dermal fillers in this area to lift the corner of the mouth, in addition to using botulinum toxin in the DAO, or you just guess that using cannula is just enough?
Very good question, Noury. Sometimes I might use a bolus, but it becomes in a little technique that I call the 3-point turn. I sometimes, if I haven't, I first of all do it with the border that I've just told you. Oh, and incidentally, just to go back a step, that pilot needle, or the entry needle as we call it, I go into the upper to take my cannula. I will take the entry needle in at that point, but when I come to do the lower, I will put another entry needle in, same hole, but I make its earlier journey in the opposite direction. So I'm not twisting the tissues. Now, just to answer your point there, if I do that corner lift with that technique, because of some of the heavier tissues hanging down, that are pressing the mouth down, or indeed you've got a slightly compressed face height. so that the tissues are slumping, I may need to use one of two other techniques to enforce the lift. One of them is what I call a 3-point turn, and it has two little boluses or two little lines in the corner at different directions to support each other. And then I do go into the commissure with a very small bolus. But if you're not careful, you get a sort of loss of an oral seal, which is terribly irritating. Dentists know all about that when patients talk about that feeling that they're dribbling, that they've not quite got, you know, the bag's not quite sealed at the top. And that's what happens at the corner. So that's my answer to that one.
And of course, you can make a combination with a little bit of neurotoxin at the depressor angulus oris to give a little bit of a lift.
Now, I found from trying that recently myself, and sometimes it helps to be the patient and the operator in one. Not that I believe in treating myself, but during lockdown, I decided for the very first time to do my own Botox. And I was pleased that I did. And not only was it the most successful that I've ever had it done, it took me about an hour to do very carefully, but I decided to do my platysma and my depressor angular oris and my mentalis muscle.
Okay.
And I discovered afterwards that my lips had actually taken on a slightly different uplifted contraction, almost into a pout. And this was actually not because I'd had anything done into my lips for a long time, but because the muscles were actually holding the lips in a different position. And I found that that was really rather good. I wouldn't have known that had I not done it to myself, because I think a patient wouldn't be aware of the muscle action that we are, so they wouldn't have given me that feedback.
And actually what you actually did in your own face, you apply the concept of indirect beautification. You targeted at different muscles to affect a remote area at the same region. You didn't have to plump your lip. You just injected a lot of other muscles and you enhanced your lips by indirect beautification.
That's right, because now
I guess the same concept goes on for the myomodulation.
There. Yes, exactly. And you can see how it's holding it.
Yeah,
and yet
exactly.
I haven't had anything into there. My other belief, of course, is that you get collagen production just by having the dermal filler in the lips. So whether you're putting it in with cannula, which if you do a cannula in the proper sense of the word and you hold it well and you don't use it like a sword or, you know, a battering ram, but you actually very delicately glide it into the tissue layers where it meets no resistance. If you do it like that atraumatically, you still get collagen production because the body knows that it's there. You won't get that unusual sort of collagen production that you will get with constant needle attack. But nevertheless, you get this collagen production. And if you do the lips as I suggest, where you shape them as you do them, you don't rely on rough massage to try and push it where you want it, you will get the lips developing collagen and producing the shape long term that you should want. So people shouldn't need their lips continually doing, you know, maybe I always think that if you're not starting with a young person with perfect lips in the first place who just wants a little uplift in size, but you're taking somebody that doesn't have very attractive shaped lips and you want to develop them better, it might be a young person, it may be an older person. I believe in the first time you get a certain amount of collagen, but it doesn't last very well. The second time you get a little bit more collagen produced and it lasts a little longer. But the third time is almost the golden time. That's when you start to really get the shape that you're wanting. And if you keep developing it, that shape will stay for a long, long time. And I you know, mine is evidence of that in the sense that I do not have my lips done very often at all. They stay in that shape. They may possibly lose a little bit of water holding capacity, but nevertheless, they still hold the shape. So
this is amazing, actually. So, Dr. Ruth, if any of our audience right now want to learn how to do the Russian lip or lip filler technique or lip tinting, obviously from what you said, they can know how to do the European lip or the natural lip using cannula and placing the filler in a very precise manner and placing it smoothly. But if people want to practice the Russian lip, how can they do it? Concerning the technique, does it also depend on the filler product that you are using it? Because I think to have this big lumpy this big gorgeous lips needs a filler with a high viscosity, or else you are gonna use like a 3 to 4 syringe of Restylane Kiss, or you can use just a 1 syringe of a Voluma or Restylane Define. So if someone wanna do the Russian lip technique, tell us more about the technique itself and the product that should be used, and when to apply it, or you just don't recommend anyone to do such a thing.
Firstly, let's define the Russian lip, because there is one now that is a bit of a hoax lip. There's something now that's hitting the magazines, which they call the octopus lip or the wavy lip.
The devil friend lip.
Exactly, the devil's lip. Now, it is believed, I've looked up on this, it's believed that there's a Russian plastic surgeon called Emilian Broad, or I don't know, I think that's how you pronounce it, but Emilian Broad, who invented the wavy brow. And they think that this is a tribute to him. But actually, one believes that it's possibly a fake lip, because I don't know that you can, I don't know that there's any evidence that you can create this octopus tentacle style of lip, which seems to be sort of hitting the press. It seems that this type of lip can be photoshopped, actually, from normal lips. So let's get that clear to start off with. What I regard of Russian lips is just maybe a 1-to-1 proportion, but really an overbuild of the lips, often from the corner right the way across, rather than going for the central, the lateral enlargement at the top and the central enlargement at the bottom, but almost like a swollen sort of bee sting lip. The technique for doing that, it may be using cannula at first and doing the technique that I described, but it's also going in with a fine needle through just above the vermilion border, quite superficially. I know 1 or 2 people who go into the muscle, which I don't agree with really, because, you know, sometimes the labial arteries are in the muscle.
It's like, doctor, it's like placing the filler in a perpendicular vertical struts along the vermilion border.
It is.
Exactly.
That's
and
right.
they tend to place a bolus at the tubercles of the upper and lower lip.
Yes, almost like a little like a little wedge shape, actually. And with the needle trauma, it makes the lips swell a lot, so you aren't quite sure exactly. I think in a way precision is not as easy, because as one side swells, you've then got to match the other side up with it, but you haven't got, you know, you've not got that precise view of what the other side looks like. There's a little bit of guesswork in there. And going through on the lower, sometimes it actually goes right through the lip, from underneath, right through under the muscle, to come out through the other side, almost in the wet dry, to lift it forwards, because it's actually pushing that lip forwards. So I think with a lot of these techniques, particularly with the people who aren't experienced, the danger is, are they landing up in the vicinity of a vessel? And I do think that they probably are riskier techniques to do, because not everybody's understanding what superficial depth is. You know, the inexperienced, the needle goes in, they can't see the tip, and they may think that they're a lot more superficial than they are. And you've got the risk of hematoma. You've got the risk of vascular occlusion. You've got the risk, if their plunger skills aren't good, that they deposit too much of a bolus, and then you get this lumpiness. And we see these in magazines, don't we, Noury? We see this type of lumpy lip. And then they're relying on a lot of massage to spread it
to,
about,
to
which
disperse the material. And actually, you can never judge on the way the lips looks like after you do the injection, because you came up with a very good point that there is always this swelling and lumps, which may give you the illusion that you have now a big lips. And once the swelling subsides, you find that this is not what I came looking for.
that's right. I pride myself in the fact that when a patient leaves, not only should they have no marks, no bruises, but I say to them, you could virtually go to the shops and nobody would think twice. You've got enhanced lips, but nobody would look at you in a way as if to say, oh my goodness, what has that person had done? And it's always because of the balance and because of the lack of trauma. I take a long time when I'm doing lips. I don't boast about doing them in 10 or 15 minutes. I plan carefully and I deliver it gently. And, you know, the patients that come to me, this is what they expect from me now. And of course, it sends that type of patient to me that wants that sort of a result. But of course, the time in the surgery is longer. Sometimes, you know, some of these other techniques, they can be cheap and cheerful, cheap materials, quick times, and you often get what you pay for. But I know I treat patients as if they were working on my face, or somebody was working on my face. I don't want to treat anybody differently than how I would be treated myself.
Exactly, exactly. Doctor, concerning the filler product, do you think that when they do Russian lips, they tend to use a product with a higher viscosity or higher molecular size, such as Restylane
I
Define, Voluma, and
I
such
would
stuff?
say, I mean, not in every case because people use
But
such a
I
range of materials,
guess if
but
this is
I would say
but
so.
this makes more sense. I guess they are not gonna use a full syringe of Restylane Kiss when they can just a one syringe with Restylane Define or Voluma. I mean, they can't have this large lips without doing using a lot of amount of syringe.
I once used volume in a younger lady's lips, and I have to say, I put it in atraumatically with a cannula in my usual way, and it gave an absolutely beautiful result.
Mm-hmm.
And I also did that with the Teoxane RHA, Kiss, or Teoxane RHA3.
Mm-hmm.
If I'm, obviously, you're not going to produce that sort of effect if you're going to use RHA2 by Teoxane or Refine or even Define. But so, yes, I would say that more than likely it is a more viscous material, a robust material. But, you know, you've got to look at the size of the lips and the skin, the stretchability of the skin in the first place. If you've got somebody who's originally had larger lips, the skin is very loose. Actually, if you weren't careful, you could overblow them into a ridiculous, enormous size because they've got loads of floppy residual skin. You've got to really hold back on patients like that. Otherwise, you could make them look ridiculous, particularly if they're, you know, ladies like me that don't want those large lips. If you've got
I
somebody
guess
that's
mostly the
got,
millennial patients who seek such a treatment.
sorry.
I guess mostly the millennial patients, 20s to 30s, who seek such trends, such as the Russian lips.
Oh, not my sort of patients, Noury. I think the sort of people that go to clinics that show photographs of that type of lip are the sorts that want that type of lip. I get young girls actually who don't want that sort of lip. They want natural lips and nicely enhanced lips, a nice proportion, but they tell me they don't want that sort of lip. So it isn't a foregone conclusion that just because you are a particular age group, a millennium, I don't think that goes. Certainly that's not my experience in this country. And I think it
I
depends on
see.
the area that you come from in a country too.
Yeah, actually, it's multifactorial. It depends on the age, the patient desire, her race, her culture. It's actually a multifactorial thing. Doctor, actually, we have reached the end of our webinar. I would like to thank you so much for giving me the pleasure to be with you again in this webinar.
It's
But I want to end my webinar with asking about something. Speaking about lips, and lips are always a tool of love and to express emotions. If you are to send a kiss for someone who is very, very special to you, whom will it be?
who would I send my love to? To my husband. My
May
husband
God
John.
bless him.
Yes, and yes, my husband John, without a doubt. I didn't even have to think about that one. And may I just thank you very much, Noury, for having me on the show on your Instagram. I've
It,
really loved it.
Thank you so much, Dr. Ruth. It was a great pleasure to have you, and I'm sure that all of our audience have learned from you as much as I did. It's always a great pleasure to have you, and thank you so much for your time and for your effort. And stay safe, take good care of yourself. Send my best regards to Dr. John and to your family, and may God bless you all.
And if
Thank you so
anybody
much.
and I just say, if anybody wants to find me at any time, then I'm near York in Yorkshire in England. And if anybody happens to be listening, then I'd love to see them.
Of course. And if anyone have a questions, go ahead and spam Dr. Ruth Brady inbox message with all your questions concerning lips
That's
and
right.
different
Yes,
techniques.
absolutely.
Thank you so much, Dr. Ruth, for your time. It was a great pleasure. Thank you for everyone who has been watching us in this webinar. Uh, 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 for a few of who doesn't know, I actually did a couple of webinars before in my Facebook page. Go to video section, check the Facebook page of my page. Check the video section. You are gonna find a couple of webinars I did with Dr. Ruth Brady about facial aesthetics. You are gonna love it. Thank you so much, Dr. Ruth, for your time.
Thank
Take
you, Noury.
good care of yourself. My best regards to all your family.
Thank you very
Goodbye.
much, and goodbye, everybody.
Thank
Bye-bye.
you so much. Bye bye. تصبحوا على خير يا دكاترة.